Dr. Jones is going to be discussing disparities in amputation and revascularization in PAD and CLI, an important topic.
Thanks, Mehdi. So we'll let the disclosures come up. I do have a few. None are pertinent to this. I think a lot of my work has been focused on disparities, and most of what we've done is actually in Medicare. I guess I'll stop and say that when we were at MedCAC a couple of years ago, Josh Beckman gave a talk that I thought was pretty inspiring. He said, PAD is the disparity. There's nothing else. The undertreatment of PAD is probably the biggest thing. And I don't have a slide for that, but and Josh and I don't always agree, but I thought that was by far the most poignant part of his talk, and it was really good. So I thought we would talk about some recent trends in amputation and PVI, discuss the inconsistent approach to patients, because that's what I think likely leads to these disparities, and then understand what's known about it, and there hasn't been that much published on it. So when I was finishing fellowship 10 years ago, Manesh Patel gave me this slide, and he said, go publish this. I said, it's a slide. Like, where's the data? And he said, that is the data, go publish it. And I didn't really understand, but and I never published from this slide, but it's a MedPAR data from North Carolina that says, where's most of amputation occurring in North Carolina? And that got us thinking about how can we deliver care within the state that we live in and the health system that we help operate in. And so kind of this royal blue here is where the highest rates are. The lowest rates are obviously the lighter colored counties. So I'll come back to this at the end. Most of the work that I've done is really looked at trends of amputation and then the factors associated with major amputation in Medicare, and then looking at PVI and how it's applied both before and after amputation in that same or in similar populations. I think a lot of our work has shown that amputation has gone down over time. It's continued to go down nationally, and most of that is due to recognition. And so that's a critical piece. When you look at the heat map and where we live in the stroke and MI and amputation belt of the South, those rates look to be about the same. And so figuring out what those factors are that contribute to much, much higher rates. Is it just that it's a higher, there's a higher prevalence of diabetes and obesity, or is it because of something else that is related to amputation? When we look at vascular intervention, both before and after, with and without amputation, you can see that the rate of inpatient inpatient revascularization is going down. The rate of outpatient and office-based clinic revascularization is going up. All of that is driven by the hope that we can increase access. And so that was the primary driving force for trying to publish some of this work. It's not to highlight that in office-based labs there maybe is less supervision and other things, but that's happening in the United States. And let's make it happen so that it's both that we're accountable and that quality occurs in those places. Because if we don't regulate ourselves, someone else is going to come in and regulate us. So I think it's, and this has been published a couple of times, but our group published that about 30% of patients who have a major amputation do not undergo any form of arterial testing before amputation. This speaks to PAD being the disparity in this setting. So I think that that could be a pulse exam. It could be an ABI formally. It could be really any form of angiography, including invasive angiography. You can see that invasive angiography is still a very low percentage of overall utilization. Some of the nice work that's been published a lot of it's been in the vascular surgery literature, has come from the National Inpatient Sample, remembering that most amputation occurs in an inpatient setting. Some of the minor amputations and toe amps can occur in a clinic or surgical suite. So in these cases, you can see that this is 121,000 patients within all of the U.S. The rates of amputation are declining. The disparities, and in this case it's really sex and race, look to be stable. So there wasn't a change in those factors over time, and that's from about a decade of 2002 to 2011. The above knee to below knee ratio was much higher for women and for Black patients. Interestingly, Hispanic patients Hispanic ethnicity was predictive of a lower above knee to below knee ratio. So it calls into question some of the things that we think about and have read about ethnicity contributing. Another pretty nice study, although now it's more than 10 years old in terms of the data, was a nicely done study published in Vascular Endovascular Surgery. You can see they actually took 3 samples: patients admitted for CLI, patients who underwent open and endovasc procedures, and those who underwent amputation. When you look at comorbidities, you can see that many of these patients actually had complex disease, including cardiac or pulmonary disease. A lot of them had diabetes, and a small percentage had renal failure. You can see that those comorbidities are relatively balanced in patients who undergo revascularization, and then as well as for amputation. They did a nice job, I thought, with looking at which patients underwent revascularization and which underwent revasc before amputation. Their conclusion was pretty spot on, that Black patients in this study of almost a decade were much more likely to undergo a major lower extremity amputation and less likely to undergo revascularization. And again, their trends over time didn't change for African American patients. How do we make it better? I've got 4 seconds, but I'm going to go over a little bit. So we got to know more about why this is occurring. Is it anatomy? Is it severity of disease? Can I look at a patient and say, what is their burden of disease going to be? Do I test that? Is it people coming to me? Is it people coming to vascular surgery? Do they just go to their PCP? Actually understanding access to care is a big problem. I don't understand access to care. I wrote a grant last year that got funded that studies access to care for PAD and CLI. I'll be very frank. Understanding how patients get referred to centers that do the work is a critical piece. We have to continue to increase awareness. Our primary care physicians are on the front line. We have APPs, like nurse practitioners and PAs, who do a lot of this work, knowing that if patients come in with symptoms or ulcerations, they need to refer to specialists. And then creating centers for excellence that may reduce barriers to care. So we need an easy button for CLI when patients get seen in clinics. Ultimately, we've got to do research in this group of patients, and a lot of that, I think, is going to be in this national infrastructure, PCORNet, the NIH and the FDA, and possibly industry. We just haven't done it before. We haven't done a lot of this work, and we need to do it prospectively, and we need to measure things that matter to patients. This is the National Evidence Center. Going back, what we did, we created a CLI group with our vascular surgeons, so it's really all 3 radiologists, cardiologists, and surgeons. We don't have vascular medicine specialists. We put people in these counties in North Carolina. I go to Vance County every Wednesday to take care of PAD patients. I have colleagues who go to other blue counties. So hopefully we're going to reduce those rates. Hopefully we can provide better care, but we got to do it systematically, and we need to do it together. Thanks.